Okay, so why is it all so expensive? Really good question, really complicated. I'm going to do my best. Healthcare costs are exploding. So what we can see in this graph is increasing in healthcare expenditure as a percent of GDP, which is gross domestic product, which is the whole amount of money that we spend per year in this country on everything. And you can see that it used to be less than 4% back in the 1920s when we didn't really have any medicines and couldn't do any surgeries anyway. And a hospital was really just a place to be warm and fed. So there wasn't much happening there. And then you see this huge explosion in costs from, the 1960s until now. It's now around 18% of our gross domestic product is spent on healthcare services. It's almost all spent on direct healthcare delivery. And the things we're going to talk about next. You might be curious, what's the budget for public health? The budget for public health is less than 3% of the total healthcare expenditures. Something to keep in mind. Maybe an opportunity there. All right, so where is all of this money going, right? Let's get an understanding of that. If you ask the health insurance companies, this is where they say all that money from your premiums is going. Now remember, most hospitals in this country are nonprofit. Also, most doctors' offices are nonprofit. If they're medical doctors' offices, they just want to be able to pay their staff and continue to operate. They don't have investors. Generally, they don't have, stockholders. They're not trying to make profit. They're just trying to work and make things go. So what you can see here is, of every healthcare dollar, right, that you spend in your premiums, about 20% of it goes for prescription drugs, so quite a bit. Another 20% goes for inpatient hospital care. Another 20% goes for outpatient hospital costs. You might be like, well, outpatient hospital costs, what's that? That's things like diagnostic services. So things like MRIs and CT scans and blood work often. It can also be outpatient procedures like having an endoscopy or a colonoscopy or a day surgery, right? So go and get a knee replacement and you go home later the same day. So that's outpatient. Then about 3% is emergency room costs, 12% is doctor visits, 6% is other outpatient care, so perhaps going to an audiologist or something like that. And then you can see that about 20% goes to the healthcare insurance company itself. So, they've kind of broken down what all their different in-house costs are as a health insurance company, and they say that about 3 cents on average, or 3% on average, is going toward profit. That varies greatly, actually, from company to company. Interestingly, this graphic is from a health insurance company organization. And when you look at the big health insurance companies, their profit margins are usually 5% to 8%. So when you just look at numbers of healthcare insurers and you average them all and you don't control for volume, you get 3% on average, because there's a lot that just make 1% and 2%, little mom and pop ones. But the big guys usually make 5 to 8% of those dollars are profit. So that means, about 60% total is going to actual provision of healthcare, and then the other 20% is going to prescription drugs. So if we look at those clinic and hospital revenues, where they all go, what's really interesting is that a sizable proportion of them go toward billing the insurance company. So even though the previous graphic says, oh, well, gosh, only about 20% total goes toward kind of overhead and the business of insurance, actually on the hospital or the clinic side, another significant portion of those hospital and clinic and doctor visit costs is actually the cost of having billing personnel who submit claims to the insurance company, process the payments, rectify disagreements, make appeals to the insurance company. It's actually quite a production. And so you can see, the typical primary care visit ends up costing, $20 of it is for the billing, the expense of the billing professionals doing the work to get paid from the health insurance company, which is 15% of the overall cost of the visit, right? So the other, $140 goes partly to pay the physician, partly to pay the receptionist, the nurse, all those things. So a not insignificant portion. So another way to look at it, from this one study is they said for a typical full-time primary care provider, right, it costs them $99,000 a year to bill insurance, right, in terms of staff, time, and salary that get devoted to this issue. So it is not insignificant. So for example, at Student Health Services, when they started billing healthcare insurance for people, they hired a company to do it for them. And the company said, okay, our fee is going to be, we get half of all the revenue that gets collected. And that was acceptable, right? So it's really tricky. The billing work is incredible. So when we look, for example, at where all the money in hospitals go, so I thought this was a really interesting graphic. So where does, if you look at a hospital's expenditure sheet, right, where is all the money going? And you can see that, of course, the main cost for a hospital, as for any service industry, is going to be, salary and benefits, salary and fringe, wages and benefits, right? It's the people who are doing the work and providing the service. So just like a school, just like lots of other service industries, wages and benefits are going to be by far the biggest part of your expenditures. And then there's professional fees, the medications that are given in-house, right? Actually in the hospital, utilities and building services, liability insurance, and then, a bunch of other things and other stuff. And this would include, like the hospital beds and the operating room equipment and all of those types of things. So if we remember how much is billing, so when you ask how many of these employees are for billing and administrative and business services, it turns out 25% of a hospital's employees on average are administrative, business, and billing folks. And that leaves 31% of their employees that are actually clinical staff. So it's really interesting to, or not, I'm sorry, 31% of their money goes for funding clinical staff, where of their wage money goes to clinical staff. So it's just kind of really interesting to see. This was a study looking at different countries and what their hospital staffing levels were like. And so the United States is in the orange box here. And this column is total healthcare staff here. And then this is administrative and other hospital staff. So you can see in the United States, we have 10.6 clinical and 9.5 other, right? So these are business people and billing people, administrative people. We have almost a 1-to-1 ratio in the United States, whereas you can look, every other country here has usually a 2-to-1 ratio or even higher. So we have a lot of administrative costs in the United States in our current healthcare system. Could it be the salaries? Is that why our physicians just overly compensated? Maybe. That could definitely be part of it. So the mean physician salary in the United States is $313,000 a year, but this kind of belies a huge spread. So gosh, I never made anywhere close to that. The mean salary for a primary care physician is now $240,000. Again, I never made anywhere close to that. But in the United Kingdom, for example, which is similar to us in many ways, and so a nice comparison country, their mean physician salary is $138, and their mean primary care physician salary is $120. So you can see those two numbers are much closer, and that's because in the United Kingdom, 2/3 of all of their healthcare workers are primary care physicians. So they are by far the predominant workforce, and they are less expensive. Whereas in the United States, we have a lot of specialists. We have way more specialists compared to every other country in terms of how we staff our physicians. Now, there is some rationale to say that perhaps our physicians should be paid a little bit more. One is that the average medical school debt in the United States, so the average medical student graduates with $240,000 in debt. So the tuition and living expenses that they had to take out loans to pay for medical school, and that then they're going to have to pay off over the next 10 to 20 years. And as you know, over the life of your loan, that it's not $240,000. It's probably going to end up being somewhere around $400,000 to $500,000 total that they end up paying back, depending on how quickly they pay off the loan and what their interest rates were. And interestingly, you can see that in the United Kingdom, the average medical school graduate has about half as much debt as the average US graduate. Now, that's not to say that US physicians deserve to be paid as highly as they are. The US also uses a lot of PAs and NPs, however, so when you actually look at our healthcare workforce, we have proportionally fewer physicians overall, especially in primary care, and PAs and NPs, their mean salary is usually around $75,000, so we should actually be getting some savings there. One place that the money goes and that we need to be really aware of is that it goes toward really expensive stuff. So this is kind of a complicated graph. I'm going to have to put my glasses on. I'm going to show you a few things. So on the bottom axis is the percent of healthcare spending, okay? And then this is the cumulative total. So what we see here is that 50% of the population spends less than 10% of all of our healthcare dollars. Right, so this is population down at the bottom. I don't think I said that correctly. Right? And you can see here the top 5% of people account for almost half of our healthcare expenditures. So the vast majority of people in the United States, even though we say, oh, the average healthcare expenditure per person is $10,000, the vast majority of people are spending far less than that. Far less than that, right? But then we have a small group of people that are spending far more than that. So we do have an outsized influence of very expensive care. So what are the things that are really expensive? Where is that money going? Very premature infants is one. Children with cancer. Adults with cancer, that can be really, really expensive. Cardiac disease, bypass surgeries, transplants, really bad car accident victims and other accident victims. Some autoimmune diseases have ridiculously expensive medicines that are really effective, but might cost, in some cases, $50,000 to $100,000 a year. So we have some conditions that we spend lots of money on. And then most of us, most of the time, do not have those, right? So there's this kind of imbalance in terms of where the money goes. The last thing that I want to point out is that we actually spend 10% of all of our healthcare money on the last year of our lives, which is a lot, right? So that last year, as we are dying, we spend 10% of all our healthcare expenditures, right? Which is, it should be, if I'm 80, that's what percent of my life is that last year? 1 in 80. So not even 2% of my life, and we're spending 10% of our healthcare dollars on it. Right, so 10% of all healthcare spending goes towards end-of-life care. We in the United States have often had a very high expectation that the doctors will be able to fix it, and I'm going to fight it. I'm not a quitter. I'm going to survive this. And so oftentimes, especially in the United States, people are getting very intensive interventions that are often, if not most of the time, hopeless. Right? But they don't feel ready to, quote, give up. And so we give some really intense care. So what you can see here is an example of how care is spent differently at end of life. So hospice, we talked about before. Hospice is when you're like, oh, I have this terminal diagnosis, I am dying, I want to die in peace, I just want to focus on comfort, quality of life, spend time with my family and loved ones, listen to nice music, whatever it might be for my last days on earth. And you can see that the cost of that service per day, even if it's residential, is quite low. Makes sense? However, people who die in the hospital right? That's a lot more expensive. And so we're usually spending about $6,000 a day on the last 1 to 3 days of their life because we're trying lots of medicines and interventions in the hospital. So it's really important to think about advanced directives. So advanced directives are things like a living will, a power of attorney for healthcare, a way for people to think about, when I reach the end of my life, how do I want that to go and where do I want it to be? Right? And then what's really important is not only think about that, but then talk about it with your family. Make sure you have a plan, make sure you have it written down. So hopefully your grandparents and your parents have all done this work and have talked to you about it, about what they do and do not want if it is clear that they are nearing the end of their lives. Because unfortunately, even though the vast majority of people, when you ask them, they say, I want to die at home. I want to die peacefully at home in my own bed, in my own home. You can see that although they may start there, right? So we've got, 39 to 52% of people are living at home a month before their death. As they get closer to the time of death, the largest percentage of them end up in the hospital, which we see in orange here. So even though people say that is not what they want, that is still where people are ending up, and that ends up being really expensive. So we need to have some honest conversations about the fact that we all die, and how do we want to have that happen, and train people and educate people about what that's going to feel like. Oftentimes when family members bring a loved one to the hospital, it's because they're panicked and they don't know what to do. We as a society have not really trained people very well for what death and dying look like and how to actually do that successfully at home. So there's a possible place to intervene there. We also spend a lot of money on prescription drugs. We are not absurdly out of line with other industrialized nations, but we pay almost twice as much as most other industrialized nations. And so prescription drug spending has really taken off in this country, especially since, around 1995, as you can see from the graph. And in fact, pharmaceutical companies have an exceedingly high profit margin in our country. So, they're making 18% profit margins, which is, right up there with the big banks and higher than media and car makers and oil and gas companies. So they are making a lot of money for their shareholders and their CEOs, because we have a market-based system, and our health insurance companies and our prescribers do not have a good way to negotiate or to put a check on those prices. So here's an updated slide from 2024, so the most recent that I could find, again looking at this issue of prescription drug prices in the United States. And although every country is spending more on prescription drugs because there are more drugs to choose from, we have the ability to treat things we didn't used to be able to. We have some amazing new medications that have come on the market. We still, as Americans, spend overall about 2.8 times as much as any other wealthy nation for drugs overall, and more than 3 times as much for brand name drugs specifically. Now you might wonder, well, isn't there some benefit? Well, this report found we do kind of get drugs available first in the United States. So I don't know if that's worth paying 3 times as much though, right? So again, we do not have the ability like many other countries do, because of how their healthcare systems are constructed, to negotiate on prices the way other countries do. Hence, our prices are higher. It is a market-driven system. Okay, so one really interesting development along those lines is that the federal government has actually started to try to negotiate with pharmaceutical companies about the cost of prescription medications for those people who are on Medicare, right? Because the federal government is paying for that, and the federal government has control over that program. So it started under President Trump actually as a voluntary program where insurance companies could agree to cap the out-of-pocket cost for insulin for seniors at $35 a month. So this was a voluntary program that they could sign on for. Why would a health insurance company do this? Probably just for PR, right? And to maybe cozy up to the federal government a little bit. There's not much to, or excuse me, a pharmaceutical company, there's not much to be gained because they're going to lose money if they can't pay a lot of money or get a lot of money from people's insulin prescriptions. But then in 2022, Congress passed the Inflation Reduction Act. And oops, sorry, I animated things in that wrong order. Bear with me. So the Inflation Reduction Act actually, for the first time ever, gave the federal government the power, right, to finally allow Medicare to negotiate for prescription drug prices. So before the Inflation Reduction Act, even though Medicare is the payer for health insurance for 20% of the population, the federal government was not allowed to negotiate with drug companies on drug prices. So this is a huge piece of federal legislation, right? So this is the U.S. Congress passed the Inflation Reduction Act. It has many provisions, but this was one of them that said you can finally actually negotiate. So what happened then is then the federal government's in a much stronger position. It was able to go to the pharmaceutical companies and say, like we refuse to pay, right? We refuse for people to have to pay more than $35 in a copay. So what you see here in the chart is the difference between those plans or those kind of programs, right? So under President Trump, that was kind of the beginnings of this. And so it was purely voluntary. It didn't cover a lot of things. It was just kind of the start because the federal government didn't have any power really to negotiate until the Inflation Reduction Act gave them that power. And so now they are able to negotiate for drug prices. And so insulin is just one of many drugs now that people in the United States who are on Medicare are going to have access to with much lower costs. Now, before I go to the next slide and tell you a little bit more about the Inflation Reduction Act, I just want to point out another provision of this law is the Expanded Affordable Care Act program. So what that was, and you're going to hear a little bit about this idea in the documentary that you watch for this unit, was strengthening the Affordable Care Act and making it easier for people to get health insurance through the marketplace. So this allowed for enhanced subsidies for those insurance premiums. So if you go on the marketplace, you can see what health plans you could qualify for and how much it would cost per month. And this expanded program gives you tax credits and federal subsidies to pay those premiums for you. So many people who are low income now, between 100 and 200% of federal poverty level, can get health insurance plans for free because of these federal subsidies. But also notice that that plan only extends through 2025. So that is set to expire. So it will be up to Congress then to decide whether to extend or reauthorize that program. So we shall see what happens, right? This is why elections matter. So again, kind of coming back to that negotiation of prices specifically for people who are on Medicare. So this is the list of agreements that they got with drug companies on the discounts that the drug companies will give the federal government for its Medicare patients. And you can see, for example, some of these are things, we've got almost 4 million people on Eliquis, which is a blood thinning medicine. And basically, they're going to cut the cost in half. So that's huge, right? Because look, it's $500 for a 30-day supply. So that's what? $6,000 a year for 4 million people, and now it's going to be $3,000 a year, which is still a lot of money that Medicare is having to pay for those folks, but still it's a significant cost savings. So this is really exciting, but I also want to point out this takes a lot of time to kind of put into place. This is supposed to start and go into effect in 2026. So remember, the executive branch, so the president, the White House, and their cabinet and their appointees and all those folks are responsible for executing the law, right? Which is why it says Biden-Harris did this, right? Because the Biden-Harris White House and their executive staff members negotiated all these prices. So when we have a different incoming administration, things could change in a variety of directions. So this hasn't yet gone into effect, and whether the incoming White House will allow it to go into effect or will modify it or will scrap it, that is all up in the air, so we shall see. Okay. So there are several reasons for the high cost of healthcare that are not unique to the United States. And these apply to kind of all industrialized wealthy nations. One is the aging population. We've talked about that before with the changes in the population pyramid. We have more older people than we have ever had before. They are medically complicated. They have higher health needs. That is going to drive our cost up. There's not really anything we can do about that. We also have more treatment options. So as Dr. Gawande said in the video that you watched for the last unit, whereas before if you had really bad knee arthritis, all we had was like a 2-cent aspirin that didn't work that well. Well, now we have joint injections, we have fancier medicines, and we have a joint replacement surgery, which can give you years of excellent health and function. So it's worth it, but it's expensive, right? So it's a lot more expensive than an aspirin. We also have high expectations. So we tend to expect that things are going to be able to be diagnosed and treated and that we are going to feel better. And we will tend to pursue a lot of diagnostic tests and treatment options until we do. And even if we don't, we will keep trying, right? That's pretty understandable. There's not all that much that we can do about that. And then some additional reasons for the United States, some of which I've already hinted at, right? So if we kind of put them all in categories. So unnecessary services and overuse. We tend to, again, so at end of life, we tend to use a lot of futile care in the hospital, for example. We also sometimes, because we have a lot of PAs and nurse practitioners, they often tend to refer to specialists more often than a primary care physician who has a more broader skill set just due to lengthier training. They also tend to sometimes order more tests, blood tests and radiology tests as well. And we tend to, feel like we're entitled to getting a lot of tests and appointments. So we tend to use a lot of healthcare in general, those of us who have insurance. We also have a lot of inefficiencies and errors, right? So again, Dr. Gawande talked about some of this. So the lack of coordination, which I kind of talked about before, is definitely an issue in our country. I've had patients that came to me and I needed to know what their blood test value was. It took so long to try to get the records from wherever they'd been seen before that I just ordered the test again, right? We just did it again because I just needed the information. I couldn't get it easily any other way. Again, that focus on specialty care, and then errors, right? So as Dr. Gawande talked about, they sometimes really simple interventions can significantly reduce our errors and improve the quality of care and decrease the cost of care. So really taking a look at those low-hanging fruit and how we can improve our systems, which is going to be the last unit that we talk about. Excess administrative costs. So we spend way more than anybody else on administrative costs, in large part because we have this very varied health insurance system with all these different billing requirements. So a good colleague of mine who trained in Canada, actually, for part of her medical training at their big academic medical center in Montreal there, in their billing office, they had 3 full-time staff. And then for her residency, she went to Boston Medical Center in Massachusetts, same sized hospital, same sized, academic medical center. And in their billing department, they had 300 staff, right? Because they're dealing with, you might think, oh, we only have maybe 10 major health insurance companies in the United States, which is largely true. But every individual employer negotiates its own specific health plan. So the fact that you have Aetna or Health Partners or Blue Cross Blue Shield means nothing in terms of the billing office. They have to track down your individual plan and negotiate with the insurance and get paid. It's different for everybody. So there's a lot of administrative costs in our current system. We also have high prices. So our physicians are higher priced than other physicians. Our drugs are definitely higher priced than in other countries, especially because we do not have that bargaining or negotiating power of what's called a single payer system, as you'll learn about more a little bit later. We also tend to charge higher prices because of a lot of bills that go unpaid. So we're all kind of subsidizing those bills that went unpaid in the higher prices that we are charged. We also, because we don't have a lot of capitation-based systems, we don't have a whole lot of preventative services. The Affordable Care Act has made some strides in that direction, saying that those things need to be covered by insurance. So, mammographies, pap smears, routine physicals, vaccinations, those types of things. Now, they didn't used to have to be covered by your health insurance. Now they do. But again, in a fee-for-service environment, which is what it still mainly is, there's no incentive really for anybody to keep you healthy. Nobody makes money if you are healthy. Everybody makes money if you're sick, right? So from the doctor to the hospital to the health insurance company, although the health insurance company wants to make sure they don't let you get too sick, and then they're just going to charge higher premiums if you do. So we don't have great incentive structures in general for prevention. And then fraud is not an insignificant part of the puzzle. When you have a highly complicated system, it is much easier for people to find little loopholes and ways to kind of get away with fraud. It's not as transparent. So a few comparisons between the United States and some other systems. If you look at healthcare expenditure, we spend more as a percentage of GDP, which is what's over here, than anybody on healthcare. We spend more than anybody as a percentage of our GDP. And because our GDP is so high, that ends up being, as measured in just total dollars, that ends up being even far greater than everybody else. So, again, we spend about $10,000 per person. Most of the industrialized nations spend $2,000 to $6,000 per person. Canada and Australia kind of come in second behind us, and most of Europe comes in third behind that. So we spend a lot more than other countries. This is the same thing, just looking at it in a different way. So this is your GDP. So this is a measure down here of how wealthy the country is considered to be. And this is our per capita expenditures. So the United States, we are quite a wealthy country, certainly not as wealthy as some others. But our healthcare expenditures are way beyond everybody else, even the wealthiest countries, for some of the reasons that we've already talked about, right? A lot of inefficiencies in our system. This is just another way of looking at it, right? So in this particular study, looking at some 2018 data, which is more recent than the previous graph, it looks like maybe we're up to almost $14,000 per person on average. Now remember, that's not equally distributed. Some people were spending millions, and some people were spending hundreds. But it is also more of our GDP than any other region. So is it working? So this graph is looking at 1970 to 2015, and it's looking at our healthcare expenditure per person, per capita, and life expectancy. So in 1970, the United States spent about $1,500 per person, and our life expectancy at that time was about 71. Follow this over time, and you can see we've made significant gains in life expectancy. We're now a little bit above 78, but look at our costs, right? And so this was, from several years ago. Still, this was only 2015, so they've continued to escalate beyond this, right? Now we're at about $14,000 per person, and our life expectancy is still about 78. If you compare us to other countries, right, you can see we spend far more even than Luxembourg, and they're pretty pretty rich in Luxembourg, and they have a much better life expectancy. So our life expectancy is terrible. Look at how much lower it is than almost every other industrialized nation, and they are spending in general far less per person than we are in the United States. This is looking at child mortality. You say, well, maybe total life expectancy isn't the biggest thing. So you can also look at child mortality data. Again, this just goes through 2014. This is an older graph. It's hard to find some more recent stuff. Again, here's our expenditure, really, really high. And yet our child mortality is pretty much as high as Bahrain, Saudi Arabia, Russia. Our child mortality rate is higher than Cuba or Poland or Greece or Estonia or Belarus. So we're not doing very well in terms of child mortality either. Okay, so before I talk about these, I want to acknowledge that, as you know, the most powerful determinants of health are the social determinants of health. So before we even talk about health insurance plans and different ways to fund health insurance plans, you need to remember, okay, so we're seeing these huge differences between the United States and other industrialized nations, despite the fact that we're spending a lot more money. But remember, the social determinants of health, your environmental ecology in which you live, determines about half of your health or more. So think about that as well when we think about the very different health outcomes that we have in the United States compared to other industrialized nations that have less unequal societies, for example, that have a stronger and more robust safety net for their populations in terms of food, housing, heat, all the basic necessities of life. Okay. So let's talk about two countries that have national health plans, or what's often referred to as a single payer system. So in this case, it's the government is the health insurer for the vast majority of healthcare that's going to take place. That means that that single payer, that one company, that government has an incredible amount of bargaining power when dealing with pharmaceutical companies, when dealing with hospitals over pricing for x-rays and inpatient stays, when dealing with physicians, right? So when we see those lower physician salaries in other countries, part of that is because the person who has to pony up the money has a lot of bargaining power, as opposed to the United States, where they don't. So in the United Kingdom, for example, that is on the left, they have a taxpayer-funded plan that covers all care. Everything is covered. It's free. There's no cost sharing involved. You can, if you want, as an individual private citizen, purchase an additional healthcare insurance plan on your own that might grant you access to kind of service with lesser wait times, or a little bit more kind of concierge type service where maybe they have nicer waiting rooms, or they seem to be take a little bit more time with you. So you can get kind of a more luxury experience if you want to pay for it yourself. In Canada, again, they have a tax-funded plan. It's not as comprehensive as the UK plan. It doesn't cover everything. Like, it doesn't cover prescription drugs necessarily. But all of the basic stuff is covered, and there is no cost sharing, there's no copays or anything like that. And then you can get optional additional private insurance to help pay for prescription drugs, long-term care, and some other things that are not part of the basic plan. If you have enough money, you will pay for that out of pocket. But if you are low income, the government will help subsidize that additional healthcare insurance for you, which is kind of a really interesting way to do it. So both of these are single payer systems, so they have a lot of leverage and bargaining power. They also have very simplified administrations, right? So it's one big organization. All the procedures are standardized. Also, their electronic health records are usually standardized, so the ability to coordinate care and communicate between different offices and different providers is really excellent. So it's a much simplified system, decreased complexity, which can decrease errors and improve efficiencies. So your activity for this unit is going to be to watch a PBS NewsHour documentary about America's healthcare systems and those of some other countries around the world. So you can kind of compare and contrast, maybe get some ideas of what are some things that maybe we want to think about doing in the United States to improve things, and maybe what are some things that we don't want to do in the United States because that isn't going to kind of work for our sets of societal values. All right, so that's health insurance and healthcare systems. We talked about some of the nuts and bolts of health insurance, the major payers, so the public insurance and the employer sponsored. And we talked about why healthcare is so expensive and particularly why in the United States, some factors that seem to drive up our costs to such great lengths. And then for most of learning about the other types of healthcare systems, I talked a little bit about those single payer plans that are national healthcare systems and how they differ from each other and how they work. And then the documentary will give you some more on that. So enjoy. I'll look forward to hearing your thoughts on it.